So which will be presenting on a said called what has been happening by the Balanced Scorecard in our hospital medical college here. And thank you, and I'll give the floor for Mr. Kiros. After that, we'll have a short site visit around some of the selected areas. Thank you.
Okay, thank you, Dr. Le. We now. So this is actually the country where Ethiopia is located, and right now the team is going to this place, which is the other team to see the hospital. So when I start the country profile, Ethiopia is actually, the projected population growth is around 8 million, while having 83.6% of the population is living in the rural area. So it is, from this we can see around 45% are below the age of 15. So again, the aged group population is actually 3%. So we can see the productive age group of the population. And the country is actually a federal state, Federal Democratic Republic, having 9 regional states. And to that time, we are actually implementing the Health Sector Development Program 3. And we face some challenges in the implementation, actually strategy-focused implementation. And we sent 3 people to study Balanced Scorecard in US, and they came and implement. But it's not like actually the way we are implementing at that time was not like what we are doing right now. So our main focus at that time was to see how individual workers will align to the activities of the organization. So at that time we are managing activities rather than thinking of the objective and ultimately how we achieve our mission and vision. So then after that, the government introduced the business process engineering in order to improve the efficiency, effectiveness, timeliness, and others in terms of the service provision. So again, we decided and we agreed with the management at that time to see Balanced Scorecard as a management and measurement in terms of the business model or the business cycle. So we are still, the thinking was at that time was activity management, not strategy focused thinking. That Balanced Scorecard was meant to be for not activity management but strategy focused management and implementation. So based on this QR, plan of action prepared and submitted actually to MLI, and then the Balanced Scorecard Institute, 2 companies were at that time vending, like the Paradigm Executive Strategy and the Balanced Scorecard Institute. Then finally Balanced Scorecard Institute won, and we started provision of training. After that we came like how the TUR was developed was guided by concept note and TUR, then how we should move, and it was approved by the executive committee, which is the executive committee means like the minister, the state minister, and the agency directors and the regional head bureau heads. And then after that, it was approved by the joint coordination committee, which is the technical arm of the framework, and we try to mix them in terms of measurement, how data-driven targets can be set in terms of reducing and achieving the outcomes. So at that time, the draft was developed and the management committee. Next phase was planning and change management, which actually Balanced Scorecard was 50% change management, which is changing the thinking, the way we are doing, and actually producing the document was the remaining 50%. So the government decided Balanced Scorecard as a strategic planning and management methodology institute, and the management committee approves the TUR to use the Balanced Scorecard, and the planning team came up with different approaches because the 8 themes was too much. So the management committee decided to bring some options. Then we tried to bring like the WHO's 6 building blocks, the business process engineering 8 core processes, and another option was the Balanced Scorecard thinking will be a working document for not only for the Federal Ministry of Health, but actually goes down to the districts and the qabalis and other ministries actually. So the last phase, which is phase 4, was strategic planning. So from the ministry, from the agencies, we mobilize actually 10 teams to develop the sector 10 teams, which the ministry was, this was chaired by the minister and the management committee, and they goes to, after they get the 10 teams, they goes to actually some far away. Actually, it's 100 kilometers away from Addis Ababa, and they started to develop the objectives and others. So this was actually at that time. Then the training was provided. Then what was in the first step? What was the organizational assessment that they gave? Then the presentation and discussion conducted the strategic teams and how to develop organizational assessment. Then helps the teams to develop. So at this phase was like the ministry has actually the mission statement, the vision statement, and then they are asked that can we reaffirm that based on the thinking that the balanced scorecard concept asks us. Then we developed our team like by seeing like its public sector. So public sector, its mission is like derived from the mandate that's given by the proclamation. So we try to develop our mandate, which actually we reassess and we reaffirm our mission and vision statement, and we try again to customize our core values. So the mission statement was actually, after the SWOT analysis, was supported by what are our strengths, what are our weaknesses, and what are the opportunities and threats that the organization has. So as strengths, like after 1978, we have the primary health care was our motto actually. So the national policy was developed in 1993. It is a pro-poor policy. So democratization and decentralization of the health system was actually there in the policy, which supports the implementation of balanced scorecard. Then the primary health care was another advantage that the strength in the sector that we saw. Then our main tenet actually focus was in the preventive, promotive, and basic creative health services. Then we tried to expand it to comprehensive health service. Then at that time we would have the 4-tier health system. Then it was after the management decides then we should have to see 3-tier system, and we should have to introduce for referral linkage 1 primary hospital in the primary health care unit, and this was seen. So we do have actually again the 20-year health sector strategy, which had clear directions from the government, and we see actually our success from HSDP 1, which is Health Sector Development Program 1, 2, and 3. Then in the national government, we do have actually the plan for accelerated and sustained development, which health was as one chapter there stated. Then health was again seen as one part, and our main ultimate goal was achieving all the MDG targets. And as you know, actually in terms of maternal mortality in child was some of the weaknesses we should have identified. So the health exchange program focuses actually on 4 major areas, and the basic tenet in the health exchange program was there are remote areas where health service coverage was not accessible. So this is actually go to the people, live with them, learn from them, love them, start with what they know, like don't tell them not new, but start from the people what they know. Then build on what they have. When the job is done, the task is accomplished, and the people will say, we have done this ourselves. Not it's done by others, but they can produce by themselves their own health. This is where it shows some of the remote areas in Ethiopia that the health workers are trying to provide the basic health services in inaccessible areas. So actually in the country we have around 33,000 health extension workers, which are women health workers, and which are in each kabali. So what's our weakness? Then we see actually this is one case for under 5 mortality. These are actually the causes of under 5 mortality, and this tells us like major cause of under 5 mortality was 72% preventable. So if we introduce like the high impact and low cost interventions, we can save like if we introduce like pneumonia causes, like it's a major cause and it contributes 28%. So if we introduce pneumonia as high impact and low cost intervention into the strategy and policy, then we can save around 60% of under 5 mortality. This is the way how it was stated. So there is no business as usual. This is the trend where we are right now, and we want to reverse it down. And we want to reach actually 67 per 1,000 live persons. This is the analyzed per each intervention that in the SWOT analysis was done. So after that, we try to reaffirm our mission and vision statement, and this actually shows how the mandate comes. So after that, we try to see, we have around four core values, then we try to minimize them to 5. So each and every staff will memorize them and will implement them in the day-to-day operation. So this is actually the main themes. Core values are community first. We are here for nothing but to serve the community. So we should have 3 priorities. One is, so after making our mission and vision, then we came to see 3 strategic pillars of excellence. That the sector is quite different from others in terms of the provision of health service delivery and quality of care, leadership and governance, health infrastructure and resources were the main pillars of excellence or strategic themes, which are identified by the Strategic Management Committee. Then each have its own result, which is decided and done by the Management Committee. So after we came here, then what we do is actually what each like pillars of excellence include and doesn't include. Like this is, it helps the Management Committee to think that what's included there and what's not included after when they develop the strategic objectives later in the next step. So this was done actually totally by the Management Committee, which we call, which is headed by the Minister, then the directorates and others. And the regional health bureaus was part and parcel of this process. So this is actually the sector perspectives. Then the first thing that the Management Committee done was, like, the first perspective was customer first. Then they think that what are different from a shop that provides support and a hospital that provides health service that cures those poor areas. So they came to see community. Then there is financial in terms of effectiveness, but in terms of community, we want to see that the community to be involved, to be engaged, then at the end of the day to have ownership. Like they should have to produce their own health like any other community. Then in terms of internal business process, we call integration and responsiveness. It's the quality of and the executive committee. Then they revise it to the strategic objectives to 10. Then after that, then they try to see the causal and effect relationship of those objectives that they need to see the ultimate result. Like having these objectives, can we meet our mission? Can we meet our vision? So can we see healthy? Like it's a sample, like how in terms of maternal mortality, the impact measure is like maternal mortality reaching 267 per 100,000 live births. Then in terms of outcome, we have the contraceptive prevalence rate by 2015 to reach 66%, deliveries attended by health professionals 60%, and the other is actually deliveries attended by health extra workers to reach 38%. So that both of them they come up to 100. So what are the vehicles that lead us to reach 267 is like we have the standard. Like a health post is for 5,000 population, a health center for 25,000 population, and we do have actually the bloodlines. We call the priorities and the initiatives. Like we have the health access program, we have the supply chain management, the regulatory system, harmonization and alignment, and others. So after that, these were the 6 steps in terms of the strategic planning and management, which is the strategic planning, the strategic initiative. So this, everyone at that time, after we developed the strategic objectives, then we try to filter out those objectives that look like initiatives in a parking lot, which we can use them later in terms of to see our initiatives. So majority of the objectives, like we have seen like 106 objectives, then we bring them to initiatives. Then finally the executive committee, the directors and others, they see the initiatives and they try to review them. And it was presented again to the regional health bureau heads and the executive committee. Then finally they decided to see the pillar initiatives that the sector will implement in the coming 5 years, taking to address the basic health-related issues and achieving the Millennium Development Goals. So after that, we came to the cascading issue. Then in the cascading, we face a gap. Then we try to minimize that gap, like cascading directly from objective to case team, which is from the sector to the ministry, from ministry to directorates, then from directorates to case team, then to the individual, how it goes. No experience actually. Then we go to Botswana to learn experience of Botswana, how they implement it. Like a group of experts goes to that area and we came up with like a good ideas how they implement balanced scorecard and how they cascade it actually. Then we learn an experience from them because they have implemented balanced scorecard with the support of actually the same company that gives us consultant service, Balanced Scorecard Institute, and we learn from them like how they are numbering each objective with performance measure, and they use actually the IIAA, which we call Issue Implication Action and Accountability Tool, which to enhance their performance and quality at their level. So the way they cascade to department from the sector, then we learn and we came back again to see ourselves. Then after that, we tried to develop a cascading manual and training in the local language, which is Amharic. Then we give numbers for each objective in the appropriate perspective and we categorize the initiatives under each perspective. This was actually not actually before. We didn't know how to number and to give weight in others. So this is actually after the experience sharing that we get from the benchmarking. Then we try to develop. Then still the balanced scorecard manual is not final. It's on the next phase of our agreement with the MLI, which is phase 2. So still we are working on the cascading manual. The current status is like each and everyone has a cascaded balanced scorecard, each and every worker, which is cascaded by objective. But the cascading we follow is like not by adding objectives, but by objective description. So this is actually like right now we are trying still reviewing our manual and others. Like we should have to cascade objectives like from the sector-wide objectives, then we have objectives for directorates, then objectives for case team, then at the individual level we'll have again smart goals and objectives. So every step has, it doesn't accomplish without challenges. Then the concept of this was new for majority. So some resistance and low attention to accept new ideas were there, mostly in the staff, not actually in the leadership. Difficult to come up with appropriate measures at community perspective was still our challenge actually. Then everyone wanted to see its directorate or unit became strategic tip. Like when you see 3, then still there are some people that they ask to add another strategic pillars of excellence. So what the strength was strong and dedication and follow-up of the BSC team, leadership commitment and ownership of the staff. To implement the balanced scorecard by majority was our strength. So currently, by now all individuals are doing their own day-to-day activities, which we call it cascading by objective description. But still we are reviewing to see like cascading by objective. So each and every directorate will have its own objectives and it will be cascaded to directorate. So the experience right now we see from Dr. Leah is actually the cascading like from the Ministry of Health Balanced Scorecard to the Medical Service Directorate. Then Medical Service Directorate will follow actually the primary health care, which is the health centers and our hospitals. So one of the hospitals which are actually accountable technically to medical service was St. Paul Hospital. So Dr. Lea will take us again how they cascade from the sector and how they implement. So this is actually in Amharic. Thank you. I think namaste and mercy. So if you have actually questions, I don't know the way we follow. Dr. Lea may present and general we will have questions, or in the general maybe if you have questions you are welcome.
It's too much. It's better we address this one then. Yes, I think yes, thank you. It's a wonderful presentation. My first question, when we are talking about the coverage, about the way your health post, when you started talking, you said 83% of the population are really in the districts. But when you are placing your health post, the population you are using to cover the districts seems to be lesser than the one you used to cover the cities. I don't know if you understand that.
Yeah, it's the standard.
Yes, the standard.
Yeah.
So probably because when I look at 83% and the provincial, the rural areas, that means the city, as you said, is not highly populated. If I understand you rightly. And secondly, there have been several management tools that have been used in the past, like the logical framework and so many other tools. What is so different from these other tools that you decided on? This scorecard. What is this scorecard really doing? What has it brought? Something new to the system? Has it brought something new that you think the scorecard is making much more impact than the old management tools that were there?
I think the standard your question is actually how, like in the rural areas, there is distance. Like every facility should have to be accessed within 5 kilometer radius. It's the standard. Like that's why we are making a range here. Like 3,000, a Kabele having 3,000 population will have its own health post, but the maximum standard we set is for 5,000 population. But when we came to the city, urban mostly they are living like in condensed areas. So we increase the standard like to 40,000 population. This is actually a new standard because we are right now introducing urban health extra workers. Those who have graduated in nurse and taking again a training for 6 months up to 9 months, then they work as urban health extra workers. But in the rural areas there are health extra workers, women health extra workers. They are graduated with 10 plus, like they graduate the pre-preparatory class, which is grade 10, and they take training for the same from 6 to 1 year. Then they work as health extra workers, but they get actual additional trainings, like which is not as part of their 1 year, but an additional training in terms of how they handle deliveries assisted by health extra workers and others, which we call clean and safe delivery and others. So this is the standard because of the distance. That's why, like, the primary hospital is for rural areas actually. Right now we are demanding, like, we will have around 730 primary hospitals. But those are not actually new to be constructed, but an expansion of some health centers to be primary hospitals to serve actually from 60,000 to 100,000 population. So they get an accessible health service, which we call in terms of 5 kilometer radius was still our standard. And because if we reduce that one, then we are requested again to have an additional human resource, which we call, still we are on the way of implementing a new innovative medical training, which actually Dr. Liam may express in the Balanced Scorecard, how the performance will be tracked, then what's the intended result. Not only like I'm doing my business today, so I will go home. No. So what the intended result that I am doing right now, it will lead me to where? Then you see the end result, not the results that you are doing right now. So the results that you intend to see. This is actually how I explain.
I can add a few points on what Kiro said. Yeah, Balanced Scorecard, it's not a new thing. I mean, there are several tools that have been implemented before, not only in Ethiopia, but in many other countries. But one thing we see in Balanced Scorecard is, one, it will help you to develop a sound strategy, and at the same time, it will help you to execute your strategies properly. And it gives you a disciplined approach, how you can line up the day-to-day activities or jobs of employees with the strategy of your organization. And the other thing, Balanced Scorecard will enable you to evaluate the performance of your organization by looking at it from 3 different performance lenses, which are internal process, capacity building, finance, and community. And it will also help you to develop a strategic map where you can communicate the strategic intent of your organization. So it helps to to avoid the communication breakdown between the departments. And last but not least, it will also help you to develop key performance measures that can indicate how well you are performing in all the 4 perspective areas. And again, the application is to make sure that leaders at all levels are spending adequate time to collect data and make critical decisions that will help to solve some of the critical problems within an organization. So some of the things are not very new, but if you really follow the 9 steps to success methodology that's also suggested by Balanced Scorecard, will help you to give a good strategic directions to your organization. So that is one of the advantages of that.
This one?
Yes. Okay, thank you very much for your presentation. And I have one question related to what Amara was saying now, and we'll get more information on that. But I apologize first because it's our first exposure to a scorecard. Maybe some question doesn't make sense, but we have to know more about it. First, your hospital is the yellow one, in the yellow box, right?
Like
it's located
from this one. This is the tiny hospital. This is the general hospital. This is specialized hospital.
Yes, sample is the yellow one.
Yes.
Yes. Okay, I was just for my own understanding. You was talking about the district level. It's just to make to understand more. I see in this map you have the health center for 30,000 people. How can we position the district in this? Because we have a primary hospital, the health center, and the health post. And at the same time, we have health centers at the urban. Does it mean that in the urban part, you don't take care of small centers there? Because sometimes in a big city with this amount of population, we need also to have the 2 levels maybe, like in a rural area. My question is, if people are sick in urban area, they have just the health centers for the coverage at primary level, nothing other. Is it right? First, and another question. He said he was asking also for the add value, because we know now funding the hospitals. Maybe it's not the case in Ethiopia, but in many of development countries, we face a lot of challenge to get funds to support hospitals, specialized hospitals. And having good tools also can help in dialogue and advocacy to get more funds to support the activities. Because she was saying now that it helps you to perform and for your own management in the center to know where you are going and if you are very performant. Does if you are using also this for the dialogue, for resource allocation, because you know this is something very critical, and if you can show clearly that you can get good result, maybe you can get more money, because we don't talk around that. You are just talking about your own perspective to follow, to know if you are in the good direction. This is good, but you have to get money to do to implement things. This can today can be an add value if really it can facilitate the dialogue with the government or the Minister of Finance or partners to get more money. And the last question, when, maybe I haven't read all the papers, do you think that is it the first evaluation, or you have many evaluation, you have done many evaluation and see how things are? I apologize again because I know it's not very easy, but it's the first exposure.
I think let me start from the last, then we evaluated like there is midterm evaluation and final evaluation. Still, the evaluation is entirely for all the like what's planned and where are we now, what's the achievements, what are the problems and others. Then there are again specific program specific evaluations. Like for malaria, it will have its own survey, like population-based survey, like your coverage will be seen, not like if I take only malaria, then we provide ITMs to the population, then we can say like 100% coverage because of the distribution. But after evaluation, then the result we get is like how many pregnant mothers did I cover, how many under 5 that I said, is the evaluation findings that will tell you like you are doing better or not. So there are actually so many evaluations that are conducted. Like if I say like in case of malaria, like in 2004, 2005, we had a study, then we see like it was around 1.6 and 1.3% of under 5 was utilizing ITMs, and 1.6% of pregnant mothers were utilizing that. So the utilization was actually almost nil. Then in 2007, after we distributed actually 20 million bed nets, then we get a result like from those population around 65% was utilizing bed nets, but when you see again from pregnant mother and under 5, like 42.3% of pregnant mother was utilizing ITM, and around 42.1% of under 5 was like sleeping under ITM. So this is actually the success that comes after study. But when you see only like how many bed needs like I distribute, then you can say 100%. So the coverages are actually triangulated based on studies. So evaluation is done like entirely for the strategic plan, like what's I planned and where are we now entirely, like as a whole, like then the others are with the program specific, like HIV will conduct its own evaluation, malaria, TB and others, and the other programs like HRH and others.
Sorry, just to clarify, was your question, Dr. Samaki, about whether the Balanced Scorecard implementation has been evaluated yet? So maybe, I think that might have been the intent of the question, whether there's been any evaluation yet of the Balanced Scorecard.
With the Balanced Scorecard, still we are in the infancy stage.
Okay.
Still, we are still trying to implement it. We didn't evaluate because we are right now finalizing the 6 steps, which we call the strategic planning. And with the strategic management, still we are on the cascading phase. We didn't reach the evaluation stage. Cascading is still like what I presented, like we are doing cascading by objective. Like there are like the first thing is spiritual cascading, we call, like taking all the objectives, what they say at the national level, then when you develop your own, then you get by adding another objective, which we call objective cascading by objective. But what we follow is like for simplicity, we use cascading by objective distribution in order to see that each and every individual implements its plan, because the government assigns budget and like each person should have to do. So still right now we are on the way of cascading. The first part what we do is like we try to cascade to the medical service directorate, then medical service directorate will cascade against the hospitals. This is the initial stage we are right now, but we didn't reach the evaluation. I was thinking the entire evolution of the strategy. So with this one, actually, in terms of how the urban cities, we may have specialized hospital or referral hospital or general hospital, and there are health centers. So this is the base for actually for the health extension workers, and it will serve actually 40,000 population. But previously, in some areas, like even in Addis, we have health posts, but that health post was not. It doesn't satisfy the demand of the people. So in the urban right now, we are still the standard in terms of the health extension worker was quite different. Here in the urban there are nurses, but in the rural there are health extension workers which are training for 1 year, but they are graduated grade 10. So this is diploma level, and that was certificate level. It's quite different. Again, they implement both of them 16 packages, but the difference was this is for urban. This is the service provided, which is linked with the general hospital. So this is actually for the rural areas, and you can see like our districts, those health centers are accountable to the district, and this primary hospital by right now is again will be accountable again to the district management. So this will solve the distance factor. This will solve again to get the service accessible, so mothers can get the service. So our professionals will locate there. Like the standard from this, like here, we will have one health officer, and in some areas we will have GP. But here there are actually around 53 technical persons, and there are specialists actually there. So this is actually to solve the maternal and newborn health problems. This is not actually with illness and others. It's the demand of the people that matters actually. So with I think this is all. Actually, in Ethiopia, all the hospitals are they get the budget from the government. Like entirely, they get the budget from the government. They have the recurrent budget and the capital budget. Now we are introducing the healthcare financing, like the waiver fee and others, retention. So majority of our hospitals, they are dependent on the government budget.
Okay. To say something about what Kiros has already presented, we all are participated how this Balanced Scorecard was developed. From health sector to the Federal Ministry of Health, from Federal Ministry of Health, that's cascaded to different directorates. From those directorates, there is also what we call the St. Paul's also cascade for that medical directorate. Or I think all the infusions related to this Balanced Scorecard, how we are cascading will be clear after I think Dr. Leah has presented. If something that's not clarified, we can also discuss related to this Balanced Scorecard.
Can I ask one kind of big question about the origin or the start of the Balanced Scorecard? There had been a number of management tools, as you mentioned, in use in the past, but I think there's an interesting story about high-level engagement by your Minister of Health, in particular, in the Balanced Scorecard, which I think he's a big champion for, and had an experience at the regional level of using a Balanced Scorecard. So I just thought it'd be interesting to share with the group a bit of that story, just from a high level, before we get into the cascading story here. Why was Minister Tedros so interested in this tool? And now there's an effort to implement the Balanced Scorecard across the government, I understand. So it'd be interesting to hear a little bit about that.
You know, so actually, before he came actually to the Minister of Health, he was working as Health Bureau Head, and I think at that time he reads like the Kalpan and Norton and other books. Then he tries to see the differences between the implementation of the ROPA, which is actually implemented at that time since 1995. Then they see the differences. Then finally he selects one of the champions actually. those who have implementing this like new initiatives, like in terms of the weekly plan and others, then they send them to get the training based on from assigning some budget. Then 3 people actually goes and get the training and they bring them to develop. Like it was at that time we are developing, we are implementing the health sector development program 3, and instructs them actually to put in the balanced scorecard perspective and try to cascade down to the individual. Then they try to implement the balanced scorecard, and it was actually his vision to see like every individual to get the direction to see the entire result. Like the way I explained the first, we are implementing in the strategic management, actually the strategic planning phase, we are using the SPM approach at that time. Our health sector development program was developed using the strategic planning and management, which is quite different from the balanced scorecard. And the management actually, the strategic management was actually again using the ROPA system, and every individual was complaining at that time. So he tries to implement, to test, and actually to other ministers to take over actually. Then after that, from since 2007 up to 2009, 2008 actually, until we start. Then in 2008, it was, there are 2 priorities, like supporting health insurance, which is at the infancy stage as the time thinking level, and supporting balanced scorecard. Then balanced scorecard was actually partial, it was implemented. The thinking was there, but it's not the way that the balanced scorecard perceptions are not implemented. Like we are implementing balanced scorecard in terms of thinking, the name was balanced scorecard, but it's like modified version of ROPA. Then he prioritized balanced scorecard by 2008. Then it was his personal actually, that like he wants to implement and to see that. I can't say at the end of the day it was the Minister of Health that tries to force other ministries to implement balanced scorecard.
So in short, can you tell us, because we all know every system has its strength and weakness, what are the weaknesses you have? Have you been able to identify any weakness in the balanced scorecard?
The one which he has presented, you mean that?
When you've started implementing?
When you start implementing, the people's are resistant to change. They are not easily changed from the previous SCPM and other management tools directly to the balanced scorecard.
That is the challenges you are facing.
Yeah.
I'm talking about the balance, the tool itself. Do you really, have you seen any weakness in it? Because you started talking about Europa, which has some gaps. That is why you want to come to balanced scorecard. Have you seen any?
Like still, in terms of balanced scorecard, the basically like selecting critical performance measures. Like they are, you follow the logic model actually. Like you start from the input and you go to the outcome. Like you focus on the outcome ones. Still, like it's selecting how the performance measures are selected and others. The other problem is actual budgeting. Balanced scorecard doesn't support for, actually there is a budget thinking, but it's not like how you cost the activities, like it follows activity-based costing or input-based budgeting or whatever. Still, it has, you can support it with other tools. In terms of when you read budgeting, or when you read evaluation, there are checklists and others. But there are evaluation methodologies that you can use. Still, we didn't reach the evaluation phase. The budgeting we use is actually marginal budgeting for bottleneck, which is another tool. Because in terms of the thinking that the balanced scorecard budgeting part is, like it uses another methodology which is called activity-based budgeting. Like that one is again difficult most of the time, because if you start activity-based budgeting, you don't see like which impacts the other. So this is actually the major limitation in balanced scorecard.
Why I'm bringing this up, people might want to see the balanced scorecard as a magic wand to solve every problem. That is not true, because what you had before, and you made significant progress, because we know the story of Ethiopia. You were using that tool, now you see the problem, but you made significant progress in entirety. So what it takes here is commitment from the people. dedication. People must be committed. And I think that's about what I wanted to bring out really. That people should be committed.
Commitment was
The critical leadership, ownership, both by every. So that when you meet these challenges, you'll be able to overcome them.
So could you follow up on that? It's a really good point, I think. Is that, can you talk about cases that you've had with managers who are completely against this? We meet roadblocks and they say, no, I don't want to do it. How do you deal with that? How do you, in the hospital here, how have you dealt with resistance?
Well, as we've seen the presentation, we just completed building the scorecard of the organization, and we haven't gone yet to the cascading to each department. But while we are building that scorecard, where each team member in the leadership team was very eager to implement and committed to the inspired by the whole concept of balanced scorecard, because it showed that it has many advantages. But when we go to implementation, of course, we should have a plan change management strategies to achieve, to tackle this challenge. But we haven't faced a department that says, no, I don't want this tool yet.
The same
Can I add one point? Yeah, like when the Federal Ministry of Health introduced Balanced Scorecard, most of the people had an understanding that BSC about monitoring their performance. So there was a lot of resistance, thinking that they are going to be evaluated and who knows what kind of measure is going to be taken. So there was a lot of resistance, thinking that it's only a monitoring tool. But once Federal Ministry of Health started introducing this tool as strategic planning and performance management. Actually, it's a tool that helps to improve the performance of employees. It is not a punitive tool. Then people become more receptive. So the change management office will have this kind of role, making sure that they are communicating this tool in providing the right information to the client to ensure that there is no resistance.
So I think Dr. Ray will continue.
We must be feeling it's under the initiative of the Federal Ministry of Health, a medical college it became a medical college with a new type of curriculum, integrated modular curriculum. And currently we have around 275 students. And it serves an average of 110,000 outpatients annually, and with a total of 831 clinical, academic, and support staff. So High St. Paul started to implement BSC at this time. We have been undertaking many reforms in the past 2 to 3 years to improve, especially focusing on the medical care of the hospital, and reform like implementing the blueprint hospital standards, which came out around 3 years back, and also implementing the business process re-engineering as part of the whole national government reform. And with all this, so we were involved in many different initiatives, and we had successes in different areas in terms of improving quality, timeliness, and cost of care, with still many challenges. But even if we were implementing many reforms, we were, mostly the management and at all level, we were focusing more on the operational things and in activities rather than having a strategic focus. So there was a need to have a strategic focus to really be good at what we are doing. And also there was a need to have a clear vision by the organization and also at all level up to the individual. Balanced scorecard training. Then the scorecard developed by the MSD was cascaded to St. Paul. I'll come on some of the steps we took during the cascading. So maybe just to say a brief thing about the logic of balanced scorecards, general logic of balanced scorecard strategic planning. as Rahil was also mentioning, on the 9 steps, these are part of the 9 steps of the strategic planning. These are the planning phase, the first 6 months. So the first step during the development of Balanced Scorecard would be analyzing our customers and stakeholders, what their needs are, who are our customers, what do we need to deliver to them, and what kinds of relationship do we need to deliver. So based on that, and after doing a SWOT analysis, then it's the development of the mission and vision, showing what's our picture for the future. And after that, to reach to this vision, in what areas should we exceed? This has to be identified, the strategic focus areas, at least few strategic focus areas. Then the development of strategic objectives, which are the continuous improvements. What do we need to do to achieve these results? And these strategic objectives are also created in a way that each can have a cause-effect relationship and bring a value for our customers. And when we perform these objectives, of course, what should we do as initiatives, as strategic initiatives, to achieve these objectives, and then to achieve at the end of the day the strategic results and the vision. And once we have this, we also have to have the performance measures and targets for each of the strategic objectives. How would we know if we are achieving the results we want? We might be doing many activities, but we may not know whether we are really achieving what we have planned. So, as I have said earlier, it was using the scorecard that was developed by the Federal Ministry of Health that the cascading process was done, but we have to go through the process, through all of the process of developing the scorecard, except that we took the pillars of excellence that the the Federal Ministry of Health has put. So we did an analysis of customers and stakeholders. I will not go to the details of that, but this is to help us develop what our vision should be and what our areas of focus should be. So as you can see, our customers, we have different customers. We have primary customers, stakeholders, what their needs are, like the customers need an accurate and timely information, quality care, accessible service. So all these were analyzed. And after doing this, and so maybe I put it later, but after also having the SWOT analysis showing what is the strengths, what are our opportunities so that we can build on, and what are our weaknesses, especially our weaknesses were the areas where we try to focus to achieve those results. So after analyzing all this, then the vision and the mission was we decided on the mission and the vision. As you can see, it is to be a sought-after medical center and a prestigious academic and research center in East Africa. And our mission was focusing on our core processes, which is medical care, teaching, and research. So these are our core values. They are since we are cascading from the Federal Ministry of Health, most of our values are similar to the Federal Ministry of Health, but we have also specific and commitment to excellence. So, as was said earlier, after developing the mission and vision, the other strategic planning step would be having a strategic teams or pillars of excellence. What are the areas which we should focus on strategically to achieve the vision? So they are similar to what the Federal Ministry of Health has, except with only slight changes, because we also have we are also a teaching institution here. So the first strategic team is excellence in our service delivery, which is in the healthcare and also in teaching. So the result is also, as you can see here. The second is if we can also focus in the leadership and governance. This excellence in leadership and governance is also on the other pillar. And the third pillar would be excellence in infrastructure and resources. So if we focus on these three pillars, then we can achieve the vision. But then this has to be also broken down to strategic objectives, more actionable. So what are the strategic objectives? So that's the area where the cascade had to add our own strategic objectives. So finally, we had the following 13 strategic objectives. We finally had, and as you can see, each of the strategic objectives can tell a story because they have a cause-effect relationship. Achieving one of the objectives can impact the other, and they are each also put in the four perspectives that was being lately. The upper ones would be more the results of all the achievements of the other strategic objectives. Just to mention some of our objectives. For example, you can see in the capacity building, we have put the strategic objective, improve knowledge and skill of staff. And the other objective would be improve staff motivation, and this would be linked as improving the knowledge and the skill of staff can have an impact on improving the staff motivation. And this would have also affect the strategic objective of improving our quality of teaching and research. So all the strategic objectives will finally have impact on the strategic results and the vision of the organization. So each of these strategic objectives will have their own strategic objective owners, and for each strategic objective, we have also selected few performance measures or indicators, and to achieve those, of course, these are continuous improvement objectives, and we need to have more actionable initiatives to achieve this. So for each strategic objectives, we have selected performance measures and initiatives, and also put targets. You'll see it also when we go out in the outside the poster. So I will not go through all the performance measures and initiatives, but just to give an example. For example, one of our strategic objectives, the final outcome that we hope to get is to get a society satisfaction, both by our medical care and by our teaching. So we have put the satisfaction of our customers to be one of the performance measures, and one of our initiatives could be strengthening the feedback mechanism for patients and clients. One could be also, for example, improve service delivery, especially improve for the. So, including all the targets, we have designed. This is the scorecard for the organization, for the same goal. So now we are at the step of finalizing the scorecard for the organization that needs all this needs to be cascaded to each department's units and then up to the individual level. So the challenge, of course, has many challenges, but as you can see, as it has been said earlier, we have been in many reforms. So this may be seen as another different change initiative, which may make what we have been doing up to now, make us leave what we have been doing up to now. But the good thing about the Balanced Scorecard is all the reforms that we have been doing are all incorporated within the initiatives in each of the strategic objectives. And the other is the process of developing the scorecard up to implementing. It takes a very long time, and that's also one of the challenges. And it's early to talk about successes, but early successes, the leadership team has a very good acceptance and motivated to implement this tool with increased ownership of programs and objectives. And we also have a very good support from the Federal Ministry of Health, MLI, and the Balanced Scorecard Institute through the MLI. So as I said, our next step would be to cascade, and to have we have already also started to have a regular communication, to have buy-in and commitment for change of, because this is mainly about change of way of thinking and change of heart and mind.
presentation. And it's really nice, I think, to see the scorecard all laid out in the poster and the entryway too. It makes it, I think, visually a little easier to comprehend because there are so many layers. So how do you go about now cascading into each of the directorates or departments within the hospital? How are you going to approach that process? And how long will that take? Do you expect?
We expect it will take this long time, but what we have done is to initially cascade to one, maybe a bigger department, maybe within the next month or so. So that we'll go all the way with that department. Since we started also by cascading from MSc, we have some idea about how we should go about cascading. And we are also involved with both in the development, initial development, and also during cascading. So that's a good experience for us because we have some idea of cascading from strategic objectives. So with the support of MLI, so we are going to cascade to one department first, up to individual level. Then we'll go about then after doing that very well, we'll go to the other departments. So it might take some time.
Right. And the point about the individual level, so you eventually will take every employee at the hospital, and you have 800 or so, you said, will eventually have his or her own scorecard?
That's what we are hoping. That's possible.
Yeah, but when you reach to the point of the case team, you're not going to see a strategic map or anything like that. And at individual level, it becomes a personal goal. So, it becomes a small work as the more you go down to the level, to the tiers. So it gets easier in some ways.
Yeah. Sorry. I think we are having a different way of looking at some of the classification, because in school we've been taught to look at employees as stakeholders rather than customers. In your own case, I see you identify your employees as customers. Why? Probably there is something you want to share with us.
Well, employees, we take them as internal customers.
Okay.
Because they are more than stakeholders. They are, of course, all customers are stakeholders, but customers will also have benefit from direct benefit from the organization, and we have a responsibility for that. They are also stakeholders, but they are more than stakeholders.
All right, so if you want to put more premium on the employees, I can accept it.
Merci par rapport à la présentation.
Thank you. This is a different explanation since we are here.
J'avais peut-être deux préoccupations majeures par rapport à ce tableau de bord.
I have two preoccupations towards the Balanced Scorecard.
Si je comprends bien, le tableau de bord, c'est un peu une planification qui est axée sur vraiment la performance, si je comprends bien.
I think the Balanced Scorecard is more
planification basée sur
it's more planification based on performance.
Parce que tout à fait au début, on a parlé de stratégie.
Because in the beginning we talked about strategy.
Dans la première présentation, on a dit qu'on avait au départ 108 stratégies et on est arrivé à 10.
During the first presentation, we were told that there were at first 108 strategies, and then we arrived at 10 strategies.
Comment cette sélection a été faite par rapport à
how is it done? This selection, how is it done?
Et dans cette présentation, j'ai vu que par rapport aux différentes stratégies thèmes qui sont au nombre de 3, c'est un peu les objectifs à atteindre qu'on va dérouler sous forme d'activités ou de stratégies.
The three themes and objectives which are going to be developed as strategy objectives.
Est-ce que c'est parce qu'au départ, il y a un plan stratégique qui a été mis en place Et
at the beginning, was it some strategies which were put in place?
Et à partir de là, on s'est inspiré pour mettre en place ce tableau de bord, ou bien c'est en fonction des besoins, même au niveau de la structure en tant que telle.
Donc, were you inspired from this other three strategic objectives or from the analysis?
La deuxième préoccupation, c'est que si je comprends bien, l'expérimentation se fait au niveau de cet hôpital.
My second question is the experiences in this hospital.
Et dans le futur, on projette vraiment d'aller jusqu'au centre de santé et les différentes structures.
And in the future, we project to go to the other departments and services centers.
Est-ce que pour cette mise en place, il faut d'abord une évaluation, parce que j'ai compris qu'il n'y a pas encore d'évaluation pour le tableau de bord. Est-ce qu'il faut d'abord faire une évaluation, voir quels ont été vraiment les problèmes rencontrés?
For the evaluation and for the implementation, do you need another evaluation? Do you need the evaluation part?
Corriger ça avant d'aller vers un peu la...
To correct some parts and to go there.
Par rapport aussi à la performance, on parle beaucoup de performance, on a vu quelques indicateurs.
We talk a lot about performance and about performance indicators.
Est-ce que par rapport à l'atteinte de ces différents indicateurs, est-ce qu'il y a quelque chose qui a été proposé? Parce que tout à l'heure, quand Laëlle parlait,
Is there something proposed towards this performance indicator?
on a parlé un peu de performance individuelle avec un peu des motivations personnelles.
About performance on the individual level.
Est-ce qu'à ce niveau où vous êtes avec le tableau de bord, est-ce qu'il y a des actes qui sont pris par rapport à des performances au niveau des différents services ou bien au niveau des différents responsables?
Is there some action taken for the performance indicator on the individuals and on the departments? It's just to have some clarity on the ideas.
I'm trying to address what I can and so if I get it correctly about the strategy, the question was about how the decrease, how it was decreased from 108 to 10. It will be addressed by Mr. Kiros.
Actually, the development of the strategic objectives was done like we established around 8 teams, and they are given full port to develop based on the 3 themes. Like they will take one theme and they develop objectives, how they will decompose that the strategic result of that pillar of excellence into objectives, and they develop. Some of them are actually activities. Like the only thing that they do is like they use or they add imperative words like improve, enhance, maximize, or boost, whatever. So when you evaluate that, because on daily basis we are trying to see there is some core team which actually tries to see and overview the development by the other teams. Then we came up that the objectives are not almost entirely objectives by themselves. Some of them are initiatives, some of them are performance measures. Then we try to filter them and we put them for another use, like in parking lot. When we go to the performance measure, we can take from them to put performance measure or to develop a strategic initiative. So this is how the process goes. Because first of all, the strategic management committee, which is actually led by the minister, develops the 3 pillars of excellence, like excellence in health service delivery and quality of care, leadership and governance, and infrastructure and resources. Then we establish 8 teams, then they go and develop. Then this is actually how the cascading, the objectives minimization comes. Like this was actually after we try to evaluate by ourselves, like by thinking like that objective, its altitude, like it seems like an activity or it seems like an objective, or is it like a performance measure? We put some selection criteria, and then we came to 16 strategic objectives. Then finally, again, when you develop performance measures, some of the objectives have the same performance measure. Then we try to omit like the remaining 6 objectives. Then we came up again to 10 objectives. This is how actually the 108 strategic objectives decomposed to 10 strategic objectives. And the development of actually the pillars of excellence is actually, it emanates from like, as the initial phase in the balanced scorecard is like conducting organizational assessment, like seeing your vision, mission, is it right or wrong, or what are your enablers and pains, what are the stakeholders say, what's the customers say, which you call, again, you see the customer value propositions, then it came to development of strategic themes. This is how the strategic themes came. Then this is actually why the sector, like health sector, is quite different from other sectors, why it is like given a mandate to serve this, is what's quite peculiar. So we came to the 3 themes, like from our analysis, like what are the pillars, like that should have to erect the Ministry of Health as, or the health sector. So why we should have peculiar. Then we came up to, as the first one is like excellence in health service delivery and quality of care is the mandate given. So to achieve this, then we have actually a gap in leadership and governance. Then we came again to establish excellence in that. Then again, in terms of infrastructure and resources, again, we see from the stakeholder analysis, we see from the customer value proposition and the enablers and pains, the infrastructure and resources. Then we came up to develop the 3 themes. I think Dr. Lea will continue, but I will come to the performance measure development in the cascading aspect. Is like in our sector we are trying, like why we are taking one directorate is for pilot testing, because if we implement entirely in the sector, then we didn't see where the problem is. Like we try to implement in one directorate, then we see the problem is, the pros and cons, then we try to adjust again, taking into consideration of the management arrangement in the ministry and others. So still we are piloting that one. The cascading is like, we are trying to, each and every individual have its own performance, which has its own balanced scorecard, which is actually cascaded from the sector by objective thinking and objective description, which have their own SMART goals. But still we didn't evaluate that one. We are trying to implement in one directorate, then that directorate will be evaluated and we learn the lessons from that directorate, then we expand to others. Maybe Dr. Lea will continue.
One more. Maybe it's outside of the scorecard, because you are an hospital in the yellow box. And how you manage the primary care here? Because you know in the cities people have to go at the health centers at first level for basic care package, because if not you will spend a lot of time to manage these basic things and be disturbed for you while you are in the yellow box. How are you managing? It's out of the scorecard because it's a challenge for many hospitals in big cities. They lose a lot of resources managing things which are not their real mandate, because they have to work on referral cases in the major case. You say you cannot send out patients, but the balance have to be more referral than the basic case. I don't know how it's just no more, because it's a critical issue in many countries, and maybe we can learn more from it.
It's by the referral system. We have the referral system, and for the first line care will be given by the health centers of the cities. And each hospital will have their own catchment health centers. Even though our hospital also has catchment health centers within the city of Addis, we are a referral hospital for all the countries, so we receive from all the regions actually. But there is the system that they have to come with a referral except for emergencies. The emergencies can come at any time without any referral. But still that has also, the system still has its own problems. In that many patients who can be taken care of at the health center level still come with a referral. So since they are coming with a referral, we have to take care of them, but they are coming because some of the health centers are not well functioning or well equipped by human resources or equipment. They would have to come to the specialized centers, even if they could have been handled there. So even if it has some gaps, that's the system that we are using, the referral system, the primary care. And now we are going towards supporting those health centers by the hospitals. Until now, most of the health centers are not supported by hospitals, so they are functioning separately. But that's what's been now planned to have support of these centers by specialists, skilled professionals, so that to avoid the unnecessary referrals. Also equipping them and improving their human resources is one issue, but also having a strong link between the hospitals it's worked on.
Quick question. I think all of us would love to be here in a year from now, where we could hear how it's working now in the hospital. But I wonder if it's already working among you personally. If there are some examples in how you see patients, how you deal with management, just in your own lives, how you're incorporating what you've learned from this management training, how you're incorporating that in your day-to-day activities. If anyone has any stories about just how they do things differently now because of this. You must be changed a little bit. Yeah.
So when I took a course of the Balanced Scorecard, and when I took that course, what I realized was that from before that time, I was just coming to work because it was what I'm supposed to do, and you don't get to see the bigger picture when you're just coming to work. But after that, I realized that most of my colleagues are not aware of the hospital mission and vision, although it was posted. And even I didn't know our mission and our vision until I took that training. And so it gave me that awareness that we were not looking at the bigger picture. We were just working just for that time, that 8 hours. So it made me realize that if everybody's looking at the bigger picture, and then you can get the results you're seeking.
Anyone else? Here, who are in charge of big systems. But I think there's also interest how it's going to change themselves.
And I can say one more. As a manager, we deal with many different problems every day, and sometimes we don't know which ones to handle and which ones to leave. So, or the days may go by focusing on the day-to-day problems. But after having this, what this has changed the way of my thinking is that I know now which areas I have to focus on, and which of the areas, even if I don't give them much time, they will not bring much change anyway. So I know where to spend or where to invest my time more, so that to bring an actual significant change.
I have one question. I think one of the advantages of BSc is it will give you an idea what kind of discussion needs to be held at what level of the organization. Like at a corporate level, you want to discuss more on strategic issues versus operational issues. Operational issues needs to be discussed at department or case team level. I'm wondering if you started going in that direction, discussing about strategic issues at the higher level versus operational issues.
Yes, we have started that. We have definitely started on focusing on the bigger issues. Even our performance, we are mainly focusing on activities that our measure not fully gone through the whole implementation, but we definitely have a change in that area.
Is it 3 minutes? Yeah, we'll be coming back here or here? For the case study. Yeah.
Case study we're going through it. Okay.
Yeah, let's take 15 minutes break and then we'll be back by, I guess.
Yeah, great.
Even when it was reflected.
Thank you. No. Deeper, but I really applaud you for this document. I think it's really quite something. It's very clear, and so people coming in can really learn from this. So I think that's great. We were just talking about performance indicators and baselines, what you have for baseline now, so you can judge later. So if you were really, the question I have is, what would be the most, if we came back a couple of years from now, what would the indicators be that we should focus on more to see if the BSC has been a success or not? And can you give us, and with some of the things that you think, obviously there's been great improvement in the hospital in the last several years for many things, but can you tell us some indicators now that you have, say with waiting times or bed patient rate or whatever, that so we can see where you are and then to see where you want to go?
Well, it would be hard to select from the indicators to show which one is critical to show about BSC, because how BSC works also needs to be evaluated in another way. But these indicators are clearly showing us, are helping us to focus on the strategic objectives. So this may not be the only indicators that we follow, but these are the strategic objectives of the organization, the selected performance measures. So maybe if we can say that ITEL needs to be seen from the results would be in the objectives which are in the community perspective. And these are mainly the strategic objectives of the 4 strategic objectives, we say improve society satisfaction, access, improve quality of medical service, and improve of capacity, improve the human resource capacity of health institutions. That's the result of our teaching. So all the performance measures for all these objectives at the community perspective would be the most important, because they are the results, mostly the ones which are going to be the effects of all the other performance in the other objectives. So I think the performance measures for those would be the one, like the satisfaction. How is this?
Well, what is it? What's the baseline now? What is patient satisfaction now? Do you measure that?
Yes, we have been measuring it, not very regularly. That had been measured randomly, but not in a. The tool was not yet standardized. We had used different tools, and we have a rate. For example, from out of 5, we had at one point around 3.7, and from 10 we had around 6.8. We had 1 score. So. But now we have, the Ministry of Health has already developed a standardized tool of survey which we are just planning to start recently, soon. So we are going to use that, and the index we have not yet. It says here we have put either satisfaction or customer satisfaction index. So this is going to be based on that index that's developed now, so we cannot say that. We have planned for more than 95% satisfaction.
Right, yes, I saw that in the downstairs.
Yes,
yeah.
So we have not used the percentage yet for baseline.
Yeah.
And what was the second question? Sorry.
No, you answered. I was just interested in just where you are today and where you think that the hospital could really use some improvement. So I think you mentioned this community perspective. Yeah.
And the other baseline, for example, for in the improving quality of health service, we have put the inpatient mortality, and the data we have now is between 4 to 5%, and we have plans to reduce to 2% or 2 to 3, at least 2% the inpatient mortality. So this is one of the.
So you have 4 to 5%, not 4 to 5.
No, 4 to 5.
Huh. Wow.
Merci. Par rapport à l'étude de cas, ça nous a permis d'avoir bien compris toute l'architecture et ce qui est déjà fait.
Which helped us to understand everything we talked about.
Et par rapport à ce tableau de bord prospectif, c'est sûr que la performance va être plus importante.
And towards Balanced Scorecard, it's going to be more important.
Mais pour moi, ma préoccupation, c'est qu'en fait, tout le long de l'étude de cas, on a parlé un peu de l'évolution des différents indicateurs, des problèmes et leur évolution.
We have talked about the different indicators and problems.
Mais par rapport à ces performances, il faut à côté des ressources pour atteindre ces performances.
With the performance, we have to.
Les ressources des inputs, ressources financières, ressources
what about
humaines.
the financial resources? And what about the financial resources and material resources?
Quelle est la place en fait de ces différentes ressources, aussi bien financières que
Where is the place of these resources
au niveau du tableau de bord?
Compared to the scorecard?
Et s'il y a un gap par rapport à l'atteinte de ces performances, comment l'hôpital compte vraiment aller vers la recherche de ces fonds?
And if there is a gap between the two, what is the hospital doing to solve this problem?
In the case study, we have not put the details of all the objectives or the performance lenses. but two of the perspectives, one is financial perspective, and the other is also the capacity building perspective, where it deals with building the capacity of staff. And for in terms of human resource, we have almost not only human resource, but in terms of capacity building, we have 5 strategic objectives, out of which almost two of them are dealing with staff. So we are giving stress to the human resource part also. And in terms of financial perspective, the most important thing for as a government hospital is not to make money, but to improve the utilization of our financial resources. So we have put also that as a strategic objective. Did that answer the question?
Could I, oh, please. Go ahead, Dr. Ba.
Merci, c'est vraiment enchantant d'avoir vu ça. Et j'ai pu comprendre c'est un établissement hospitalier.
I understood that it's a hospital
qui veut s'initier au sommet de la performance.
Who wants to upgrade to excellence to performance.
Et d'être aussi une référence pour le pays et pour la sous-région.
And wants to be a reference for the region and for the country.
D'après ce que j'ai lu aussi, j'ai dit que c'est un établissement qui a vocation de régler le problème des plus démunis.
And what I have read, it's an organization where it's here for the poor.
J'ai lu en prélude que les soins étaient gratuits.
That medical care are free.
Et que c'est un établissement aussi qui a été transformé en centre hospitalier universitaire.
And also it's a center which is transformed into university, into medical college.
Donc s'il veut s'initier au sommet de la performance, il faut une certaine autonomie.
So if he wants, if this institution wants to upgrade to excellency,
dans le cadre de la production des ressources.
It must also be independent in case of the resources.
Donc s'il y a gratuité et aussi le centre hospitalier universel, et vous avez dit aussi des changements dans les attitudes et comportements.
So if there is something free and also medical college and change in the attitude.
Et on sait aussi que par tradition les centres hospitaliers universitaires ils ont des traditions lourdes.
And we know by tradition that medical colleges have a big cultural.
Au niveau du corps enseignant, c'est le changement d'attitude est difficilement observable.
And by the level of the professors, this is a big factor.
C'est des traditions difficilement modifiables au niveau du corps enseignant universel.
It's an attitude which cannot be changed very easily.
Je me demande maintenant par rapport aux ressources, où est-ce que nous vont l'épuiser, parce que les enseignants ici, il y a les étudiants aussi sont là à faire des stages.
Donc, for the resources, I want to know where do you get your resources? There are the students and...
Moi, c'est par rapport à ça où j'ai quelques inquiétudes.
And my worries is towards this.
Par rapport à l'autonomie de gestion et par rapport aussi à la transparence dans la gestion.
Towards autonomy and transparency of the management.
Comme je l'ai dit, c'est par tradition des universitaires n'ont pas la manie de partager quelque chose.
By tradition, universities do not have the habit to share.
C'était ces risques que j'ai prévu si c'est le gouvernement fédéral qui leur alloue des ressources, est-ce que c'est viable s'il n'essaie pas de produire les propres ressources?
How is it viable if it does not produce
Il regarde à ce qu'ils ont voulu faire, performance dans la prestation des soins, réduire le temps d'attente et tout ça, s'ils ne sont pas autonomes financièrement.
If you cannot get your own money, it's going to be a problem for the future.
Well, you are right. Up to now, this is a government hospital where all the budget is allocated by the government. Annual budget is always allocated with the incremental budgeting every year for covering all the operations and salaries and capital. So the revenue that it's not completely free. It's not we don't give free service to all, but most of our patients get the service for free. But we also charge for others. This was a previous system. The patients who have a free paper from their local government can get the service for free. So all the service that they can get within the hospital is free, and that's by subsidizing by the government budget. But we also had some additional budgets, like the pharmacy. We have a selling pharmacy, which also makes some money to support the hospital infrastructure or other operations. And recently we also have a private wing, which mainly most of the revenue goes to the professionals and the staffs to retain. That's mainly to retain the staff. But the government, in most of the regions, there is now a newer policy where all the revenue that the hospitals make is they can retain that, and they don't give free service, but for those who require free service, their local governments pay for the hospitals. But that system has not come to the federal hospitals yet. So we are hoping if that system comes to us also, we can sustain ourselves and make better revenue to improve our service. Also the teaching demands, it needs a lot of money. Still we are using the government allocated budget, but we are hoping to change to that healthcare financing system.
Okay. For me, it's just maybe to congratulate you again, because in my understanding, you are trying to improve the management in your organization. And what I keep is that you are trying to establish this method of working, and you choose this tool. And you are not very far in implementation, and you cannot, for me, it is difficult to conclude now or to judge. But you are trying to track some missing pieces and try to readapt things. And as John said, it's very honest to put on the table all the challenges you face. And for me, this is a good thing, because it means that you know what are the bottlenecks and you can try to readapt progressively. Because I was very interested by the scorecard, but knowing that you are not very far in the implementation, I will go slow down and wait and see how things will go. And something very concrete coming from our college, I think it's very honest. He gave us an example coming from an organization like a hospital, because often people come to work day by day. They don't worry of what will happen tomorrow and if it's sustainable and everything. No, I just come to do my work. It's very important today, because in the health system, all these services are linked to guarantee the continuum of care at different levels and to deliver MDGs. If it's the case, because we are talking about health system strengthening, this means all the boxes in the system have to be complementary to deliver. And bringing this kind of thinking in an organization as an hospital is not often the case, and I think it's a very challenging thing you are going to face. And for me, it's not easy, because the first thing is the staff himself, to make sure that the manager is one thing, but the other persons are another thing, and all the other stakeholders and workers in the hospital, we have. I'm making linkage with negotiation, because it's a continuum. You are negotiating every time at home here to make sure that everybody is working in synergy. Because if this pyramid you draw at the top level, the missions are clear, but at the end of the day, everybody have to converge to the same vision. And it's just to congratulate you again and say it's not a very easy task, but I understand that you are in a good way. But we will follow you. Thank you.
Et donc cette hiérarchisation, je ne l'ai pas bien compris, je ne sais pas quel est le sens de cette hiérarchisation. Est-ce que c'est une très bonne chose?
In fact, he didn't get the fact that activities are presented in hierarchy, and the implementation of the balanced scorecard at the ministry level and at the level of the hospital, is it linked? If ever there is a problem at the level of the ministry, will it have impact on the activities of the hospital per se?
Ok, la dernière question, donc, c'est les questions de texte. Alors, avant la mise en place de ce tableau de bord, il est certain qu'il existait des textes qui régissaient en tout cas ces structures. Est-ce que dans la mise en œuvre, il n'y aura pas de conflit entre ce que les textes disent et ce que l'on veut mettre en place à partir de ce tableau de bord prospectif? S'il n'y a pas besoin de revoir un peu le contenu de certains textes qui étaient là auparavant?
I imagine that there are legislations that existed before this balanced scorecard was utilized in the hospital. So when you came to the implementation of this system, were there conflicts between the legislations and some of the points of the balanced scorecard? Some of the elements of the balanced scorecard?
We are not an autonomous hospital. We are under the Federal Ministry of Health, and but recently we have a board now. So the idea is to make us a semi-autonomous organization, but still the board will be accountable to the Ministry of Health. And the link between, of course, there is a link between, since we are under the Ministry of Health, there is a link between what the Ministry of Health is doing and what our hospital is doing. And in their balanced scorecard, they have objectives on improving or supporting health facilities under the Ministry of Health. So if anything is going wrong there, then it might affect our what we do here, but not entirely. But it might affect us. But still, there's something that we do also independently. And the last question about the legislation. There's not as much thing that would be conflicting, but maybe until now we have been using for performance evaluation of individuals. We have been using a specific tool that was being used by the Civil Service Commission. So that might change. That will definitely change with the balanced scorecard. So when we reach up to that stage, we'll have to see how to harmonize that with the legislation.
I understand that the hospital, I mean, I may be wrong, but the hospital is under the Directorate of Medical Services at the Federal Ministry of Health. Now, the Federal Ministry of Health hasn't really cascaded the balanced scorecard down to the directorates yet. Have you? It's going down.
Inside the ministry.
Within the ministry. So I'm wondering whether the Directorate of Medical Services has actually done the balanced scorecard before you have done yours?
You know, actually what's done is like first we gave some time actually from Balanced Scorecard Institute. There are two which they provide other training. They came and they support us in the cascading process. And then after we cascade, it was the third step that this hospital cascaded down.
Okay. So it's been done in the directorates, in the ministry.
Yeah.
But you haven't done any evaluation of it in that.
It's an early stage.
Okay, yes. Thank you. I understand from your presentation, you did the BPR before, Business Process Engineering. And when you were introducing this balance score, do you have to do another restructuring of your system so that you can be able to operate or work within it properly? Or did you just use it in the existing structure that you had? Was there any need for any change? Okay. And one thing that intrigued me about this case study is the last paragraph. You said, in addition, the DSC will help to identify and reward high-performing individuals, eventually leading to retention of valuable staff within the hospital. You know, some management tools most times look at the problems, that is strengths and weaknesses, and provide solutions as well to address them. But now you are going one step further to looking at rewards. Is that really part of the balance score system, or is it another system that you're using to complement this DSC?
There's a need of, we are waiting for one legislation to come out for that, to finalize that restructuring, which happened with the BPR and with becoming a college. So we are only going with that restructuring, and we haven't found the need to restructure entirely by the Balanced Scorecard, but one of the areas we identified when we did the SWOT analysis and when we are planning in one of the initiatives of improving governance was that we needed to improve our structure. So since we have not fully implemented that, the structure that was designed by the BPR in the college, it had given us the opportunity to review it again with the Balanced Scorecard. So it had given us a good chance. So it's going to be implemented once the legislation has passed within the next couple of weeks. The other thing is about the rewarding. One of the problems that we have identified is that our system is not, there is no clear system that we have to identify who's performing where the measures are not very clear at an individual level to know. We sometimes know people who do well, but clear objective measures. So if we are hoping that this tool within the Balanced Scorecard itself, once it's cascaded to individual level, would help us to identify people who are performing very well, and so that we will institute the performance-based evaluation enhanced with the rewarding system. Because for now, for example, when people are not performing well or when people have some disciplinary problems, we could punish them, but if we don't have the balance of rewarding also, that will not motivate the staff and create a good working environment. So we are hoping that this same tool of Balanced Scorecard would bring that. Till now we haven't thought of using another tool because we expect the center to help us.
I think really the Balanced Scorecard will identify people who are doing well.
Yes.
But
rewarding, yes.
That is my concern. How do you go about making, giving this? Because if you look at the PBA, the method of rewarding, it's so complex. You have so many criteria. So I'm wondering, do you have those things in the balance score? How are you going to do it? Yes.
Actually, in our country, there is a civil service commission which actually works with staffs. like there is a proclamation like how you give incentive for an individual after evaluating. There are criteria, there are standards, there is guideline. And that guideline is like first consulted by high-level officials at the government level, then it came to technical persons, then it came again discussed, then it came to individuals. So each ministry will again adapt that one, and then the others will take again. It's like it will again cascade it down that one, that manual. Like the generic manual will be prepared, and then each individual again, ministry or actual at ministry level, the HRH department will develop that one. Then after customizing and adapting, then there are financial and non-financial incentives will be identified. So if again those financial and non-financial incentives are after they identify, then who will get? Then after evaluation, what was the grading point? The grading point matters, like to get the incentives. Like if everyone falls like the normal curve below average, then no one will get the chance. So this is, it has its own standard in manual, but you couldn't get it in the balanced scorecard.
Thanks.
Just to add one point to this rewarding system, we and the BSC, I and my BSC consultant got a chance to meet with Minister Tedros, and we asked him, why do you really want this tool to be implemented at this very specific time? And one of the reasons that he gave us was he was really concerned about the high turnover within the health sector. He said he is losing a significant number of highly skilled health professionals. So this tool, he said, is going to help him identify who are the good performing employees within the health sector, and at the same time he will enable him to reward those highly skilled, high performing individuals. That way he will be able to retain some of the highly skilled professionals within the health sector. So Balanced Scorecard is a framework, but within this framework you can even use balanced performance-based financing, things like that. That will help you to attach. That will help you to link with Balanced Scorecard. That way you can attach incentives to high-performing individuals, and eventually this kind of process will help you to retain highly qualified health professionals within the health sector. So I guess it's about time. We have prepared this case study so that you have a good understanding on application of Balanced Scorecard, besides the presentations that were made by Kiros and Dr. Leah. I hope this was a value-added exercise for you. Thank you so much for your time and patience.
Thank you all so much.
My name is Leah Taddesa. I'm an obstetrician and gynecologist by profession, currently working as a Vice Provost for Medical Services here at St. Paul Hospital Medical College. Currently here at St. Paul we are implementing an initiative called the Balanced Scorecard Strategic Planning and Management System. This system this is an initiative of the Federal Ministry of Health, and with the support of MLI, it was started to be implemented at the ministry here in Ethiopia. And after developing the scorecard at the Federal Ministry of Health, it has come to our hospital. And here, the team here, the leadership team here at St. Paul has found this tool to be a very good tool to help us improve our performance and the care that we provide for our patients, and also now that we are a teaching institute, also the type of teaching that we provide. In that this is a system that helps you to be strategically focused and to be focused on day-to-day operations, so that you can excel on these areas to achieve a clear stated vision that for at least for some years after now. And also this tool we are hoping that it will also make everyone own the vision of the organization than be working for their day-to-day only just as a day-to-day operations, but be owner of all the organization's mission and vision. And we're also hoping that we also believe that this tool will help us to know in what areas we're making progress, in what areas we need to improve, and have a clear objective measures of our performances so that we can achieve our vision at the end of the day.
What kind of performances do you hope to improve?
Well, in terms of the medical care that we provide, we hope to improve, for example, the wait time of our patients. The patients, when they come to be seen by their doctors, the wait time sometimes tends to be too long due to different reasons. So we want to improve the wait time. We want to improve the quality of care that we provide for our admitted cases, so that, for example, the mortality in our hospital would be much lower, and we want to give a very compassionate care so that we have satisfied clients. We want to produce competent and compassionate medical doctors by our medical school. So these are just to highlight some of the performances that we want to improve, and improve our efficiency in terms of seeing the number of patients, the number of admissions we have, by improving our bed occupancy rates or lengths of stay in our hospital. So all this would have an impact.
Are you excited?
Yes, very much. Excited, also challenging. It's going to have its own challenge implementing the whole scorecard, but it's very exciting. It's going to be an exciting journey too.
I'm Rahel Gazal, the country lead for Ministerial Leadership Initiative for Global Health. Today we are at St. Paul Hospital, and the reason we are here is we would like to share the implementation of Balanced Scorecard with MLI countries. Balanced Scorecard is a strategic planning and management tool that helps to give strategic focus to the organization, and at the same time to align the day-to-day work of individuals with the mission and vision of the organization. This initiative is very important because, like I said before, it helps to give strategic focus to an organization by aligning the day-to-day works of employees with the mission and vision of the organization. And this is also a very important tool to improve the performance of the organization by looking at the performance of the organization from 4 performance lenses. So I think after this visit, I think the participants got adequate knowledge on the application of BSC that they can take to their ministries and possibly implement it within their organization.
So if you're a poor person in Addis Ababa, should this impact their lives, Balanced Scorecard Initiative? How is it going to help them?
If the ministries are, the purpose of ministries is to serve the disadvantaged and poor people by improving the quality of service that they provide to them. So if the performance of the ministries, if the performance of the hospitals has improved, it means that quality health services will be delivered to poor people. So it's very important for them.
And why will the Balanced Scorecard help improve the performance?
It helps to improve the performance because it gives a disciplined approach how organizations can develop key performance indicators that helps them to track their progress over time, but in the meantime it will also help them to develop initiatives and projects that helps them to meet the targets in various performance areas.
Are you excited to see the start?
I'm very excited to see this start. I'm very convinced that this is a tool that can help the whole sector improve its performance if it is properly implemented at different levels of the health sector.